Okay, and welcome to the Davies Use Case webinar being presented by California Correctional Healthcare Services on improving advanced liver disease outcomes using patient registries. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and values. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar, Dr. John Dunlap and Michael Selby. Dr. Dunlap and Michael, I will turn the presentation over to you, and you can begin when you're ready. Thank you for joining us today.
Hello, and welcome to California Correctional Healthcare Services HIMSS Davies Award presentation. Today we're going to talk about improving advanced liver disease outcomes using patient registries. My name is John Dunlap. I'm the Deputy Medical Executive for the Quality Management Unit at California Correctional Healthcare Services, and my co-presenter is...
I am Michael Selby. I'm the Health Program Manager 3 over the Performance Evaluation Team within the Quality Management section.
So today's agenda for the presentation, we're going to describe our local problem, then discuss our design and implementation of our health informatics solution. We're going to talk about how the information technology solution was utilized and the value derived from that. So our local problem. In California Correctional Healthcare Services, the California prison system, that is, we have 125,000 inmates, and of that, we currently see we have about 2/3 of our population with substance use disorder. 15% of the population is known to have Hep C infection, and about 1.6% or 2,000 of those are identified with cirrhosis ESLD, end-stage liver disease. So we know that advanced liver disease has been a major contributor of morbidity and mortality to the California's incarcerated population. In fact, it's been the second or third leading cause of death among adult offenders every year for the past decade. So really quick, for those of you who are perhaps are non-clinical, cirrhosis or end-stage liver disease represents a late-stage scarring of the liver cells, which is characterized by distortion of the cell structure, and therefore it diminishes its functionality. In its advanced stages, it's considered irreversible, and really the only option at that point is liver transplantation, which, not surprisingly, our population is not eligible for in almost all cases. Patients with cirrhosis are susceptible to a variety of complications, and their life expectancy is markedly reduced. So the fact that our population sees a disproportionate number of patients with end-stage liver disease is what really is driving this. According to the CDC, the United States approximately has 0.27% of its population identified with advanced liver disease, whereas we are seeing 1.6% of our population. So prior to the new solution, the state we were in was that our primary care clinicians, who are board certified family medicine and internal medicine predominantly, just did not have good training or experience from their private sector dealing with advanced liver disease patients. Also, our organization was not providing clear guidance or evidence-based support tools to the providers. Because of the nature of our business, the inmates that we care for are moved around quite a bit. In fact, our population sees about 11,000 movements every year, every month. So really, that translates to about our entire population on average moving at least once per year. And then the last piece is that we did not have an EHR at the time, so we had a really hard time tracking and monitoring these patients. So as I mentioned before, we have mortality trends that we did analysis on, and where we saw over the last decade reduction in overall cause mortality. We did also see some trends that paralleled for cancer and cardiovascular disease that were similar to the all-cause. But you see at the bottom line here on the right is our ESLD patient population, and that basically shows no improvement over the time. So this was really sort of a population we thought we could do better care for. So what we wanted to do was to find a way to utilize the information we had available to us, and basically the data that the data sources we had available to us could be used. And what we wanted to try to accomplish was identify and diagnose patients who had advanced liver disease or cirrhosis early. We wanted to make sure that evidence-based guidelines were being followed, ultimately to reduce preventable morbidity and mortality through improved continuity of care. So administratively, we also wanted to be able to track the patients throughout their incarceration, provide timely and actionable information to the clinicians caring for these patients, and then provide near real-time performance reports to both providers and managers. Okay, moving on to design and implementation. So evaluating IT solution alternatives. So commercial off-the-shelf products were not available. There really was nothing that we saw that was targeting population health management specific to end-stage liver disease patients. Again, probably because the outside community doesn't have the volume that we have. So existing resources, though, we did have our in-house talent of clinical and technical people, and we had a SQL-based healthcare data warehouse for reporting. So by putting together our programmers and clinical SMEs, we were able to produce both some performance measures and a patient registry that identified the purpose or the targeted interventions that we wanted to ensure the patients were provided to improve patient outcomes. So our clinical SMEs were involved by basically developing evidence-based guidelines. So here you see just some screenshots of a few of the pages that we provide. And we basically have a summary page, we have some decision support pages, and then there are additional pages behind this that are patient education and self-management tools to help. The clinical SMEs also were influential in defining the workflow and helping to train our the front-end users. But really what these slides are showing is this is the step-by-step process of just one of the actions taken that the front-end clinicians have to do to document within this. our technical people, Mike and his team, will sit down with clinical people to understand how to map the front end stuff to the back end in the data warehouse. So again, this is a very busy slide, but really what it's doing is it's pointing out that we're pulling laboratory results, imaging results, procedures, diagnostic reports, and the like, just as a different variety of informations that we use that go into the registry methodology. All right, I'm going to turn it over to Michael now, who's going to talk about how the IT solution is utilized.
All right, thank you, Dr. Dunlap. So once the clinical guidelines around end-stage liver disease were in place, and we had identified the data points used to identify ESLD patients, we were able to build an end-stage liver disease registry. So this is what it looks like. This is a SQL Server Reporting Services report, which pulls data from our back-end SQL Server data warehouse. SQL Server Reporting Services, or SSRS, is a Microsoft commercial off-the-shelf product that allows staff to build these front-end reports that then other staff are able to access through a web-based portal. It integrates very well with a SQL Server backend, but can also connect to other different types of data sources. Essentially, whatever your organization needs or uses, you can usually connect that to a SQL Server Reporting Services report. So, functionally, this registry is an automated report which shows patients that we have automatically identified as having ESLD through our clinical rules. Now, each patient gets one row on the report, and then we display various information about that patient and their condition across the row. So on the left, we have basic patient identification and housing information. Then we show the status of the 2 screening tests the patients need, ultrasounds and EGDs. Then we show factors related to management of the condition and various sub-conditions. And then we show their most recent platelet count and creatinine values on the right. The basic functionality of this and our other patient registries includes automatically detecting a user's assigned institution and showing the end-stage liver disease patients at their particular institution by default. They can also view patients at any other institution, and due to both the relatively small ESLD patient population we have, and the fact that we have an infectious disease specialist here at headquarters monitoring this population at a statewide level, we added the ability to see all ESLD patients across the state in one report. On the other end of the spectrum, we also give providers the ability to just see the specific patients on their particular care team or patient panel. Now, another important feature of this and our other registries is color coding. We use red to show when something is overdue or shouldn't be done, and yellow to show things that are due soon. In the case of the ESLD registry, we flag in red any patient with an overdue ultrasound for hepatocellular carcinoma screening or an overdue EGD for ascites detection. If either of these are coming due in the next 3 months, that box will be highlighted yellow for that patient. In the case of ESLD, there are some associated conditions that also need monitoring, including ascites, esophageal varices, spontaneous bacterial peritonitis, hepatic encephalopathy, and hepatocellular carcinoma. And this registry both identifies patients with those associated conditions and flags in red any patient who isn't receiving the appropriate medications based on their associated conditions. It also flags in red any patient on a longer-term NSAID, as you can see over on the right, as those are contraindicated for end-stage liver disease patients. In addition to color-coded flagging, we also include the ability to sort on any of the columns in the report. So for example, in this case, we have sorted on the ultrasound column, which brings patients with no ultrasounds at the very top, followed by those with overdue ultrasounds, followed by those in yellow, which are due soon, and followed by those who've been done recently, ordered by the age of their ultrasound. This allows providers to easily see all the patients in their panel that need either initial or repeat diagnostic testing. Similarly, we also include a number of filters in this report to just filter down on the patients who need different types of testing or care. So they can see new patients on their panel, or they can see patients with specific subconditions, or patients with different diagnostic tests that are overdue. This particular report also has a patient profile view, which staff can access by clicking the patient's last name on the registry itself. So clicking that brings up this profile view, which shows a number of data points helpful in treating end-stage liver disease patients. This includes information on hepatitis C and hepatitis B lab results, a calculated fibrosis or FIB-4 score, a listing of their current medications related to ESLD, as well as their other medications, a history of a subset of their lab results over the last year, information on diagnoses that have been entered for that patient related to end-stage liver disease, and finally a history of their ultrasounds and EGD procedures. And then, like our other patient registries, clicking on a patient's identifier number will bring up another report we call a patient summary report, which consolidates about 20 different data sources into a one-page view of a particular patient. That also links to the patient risk profile, which categorizes each patient into either high, medium, or low risk, and it's also linked to other tools. Now, at the same time that the end-stage liver disease registry was released, new measures were also added to our healthcare services dashboard that monitors prisons' compliance with the guidelines described in our end-stage liver disease care guide. So the healthcare services dashboard is a performance monitoring and surveillance tool to monitor how our organization is doing overall. So it's something that staff at all levels look at all the time, and so we put a measure on this report related to our compliance with our guidelines to track how well we're doing. In this case, as with many of our other measures, there's a top-level quote-unquote composite measure that shows an overall score of end-stage liver disease compliance and component scores below that composite score that look at each type of care. So in this particular case, we have two component scores around getting EGDs to check for esophageal varices and hepatocellular carcinoma screening, those next two measures. We have a measure on the avoidance of NSAIDs, and then the bottom three measures look at whether or not patients with associated conditions are receiving the correct medications. We calculate these scores at both the statewide and the institutional level, and most recently we've broken down the scores by particular care teams or patient panels as well, so staff at all levels can really see where improvements are or are not being made. And this will enable staff at all levels to monitor compliance with these requirements and to focus improvement efforts on where they're needed. Like the registry, the dashboard scores are also color-coded so that users can see at a glance how well the process is working. So if the scores are green, they're at goal, which in this case we have set at 90% compliance. Scores in yellow are close to goal, 80 to 90% compliance, and scores in red are those below 80% compliance. Finally, in order to increase transparency in our measurement process, we also have a patient drill down for each of these measures. So clicking on any of these scores will bring up the list of patients in the denominator and what factors made them fall in or out of compliance. The drill downs plus the registry help institutions identify patients out of compliance with our requirements. Now, the dashboard measures are backward-looking in that they look at what should have been done in the past. Our registries are forward-looking in that they show what needs to be done now or in the near future. And by aligning the color coding on our registries with the methodology of the dashboard measures, we're able to tell people that if you get the red off of your registries, your dashboard scores will turn green. All right, now both the end-stage liver disease registry and the associated dashboard measures can be used in a variety of ways by different staff. As you see Dr. Dunlap doing here, you can get to these registries through our electronic medical record system, which they may do while they're seeing a patient to see if there are any tests that need to be ordered or treatment started or discontinued. If they need to order any tests or change any medications, they could do it in the EMR right then and there and educate the patient about what they're doing. Another thing we're requiring institutions to do is hold what we call population management working sessions twice a month. These are meetings with 1 or 2 clinical care teams, including the medical provider, registered nurse, LVN, and their medical executive. At these meetings, staff review the various registries produced by the quality management section to find their quote-unquote red areas and either order any tests or medications right then and there, or discuss intervention strategies with harder-to-reach patients. So how did we build this? So at the time we built the end-stage liver disease registry, we already had a fairly robust infrastructure in place in terms of the existence of a centralized SQL Server data warehouse and a number of other patient registries that were already in existence. I'll go more into the SQL Server in the next slide. But so the other registries we already have included diabetes, asthma, HCV, HIV, and mental health conditions, among others. So for this project, we really were able to leverage this existing infrastructure in terms of that back-end SQL Server and the front-end SQL Server reporting server, which staff were already used to accessing for the other registries in the dashboard. So the main infrastructure is we've got this SQL Server data warehouse which pulls in all these disparate data sources and which then is fed into a centralized location. One of the interesting parts of this particular project was that we had this essentially rudimentary EMR called the Patient Health Information Portal, or PHIP. This was a homegrown IT-built application that allowed providers to enter and see diagnoses and procedures such as vaccinations and cancer screenings. At the time we were building the end-stage liver disease registry, we didn't have a good way to timely track the completion or the refusals of EGDs or ultrasounds. So as we were building the registry, we also worked with our local information technology staff to change this rudimentary EMR application so that providers could enter information on completed or refused ultrasounds and EGD tests, as well as the other procedures they were already entering. And then by IT making those changes to their application, we were able to continue to get an automatic feed of that data into our data warehouse, which allowed us to display those data points on the registry and use them in the dashboard calculations. So this is, at a high level, what our backend SQL Server data warehouse looks like. So on the left-hand side, we have a number of data sources feeding into a centralized location. So we've got our electronic health record system plus other healthcare systems feeding in. We have SALMS, our custody application, feeding information in. And then we have a variety of legacy applications as well as other data sources such as like SharePoint lists or Excel files, which either get automatically or manually loaded into the server. And then we take all that raw information and run it through an ETL, or extract, transform, load process to turn that raw information into more structured, usable information. Once that process has happened and we have the more structured information in the data warehouse, we're then able to do a variety of things with it, including performing ad hoc analyses or data mining. These frequently come from questions that our executive leadership may have about how well certain programs are going, and so we're able to leverage the data in the data warehouse to quickly get an answer to those questions. And then it feeds into our front-end reporting. So all of our SSRS reports, including the dashboard and all the patient registries we have, including this end-stage liver disease one, are all fed from this back-end data warehouse. So my staff work very closely with our clinical SMEs, like Dr. Dunlap, to design the front-end view of the end-stage liver disease registry and how the dashboard measures calculate compliance. So we do this to ensure that our tools are aligned with the clinical care guides and that the information we display makes sense to the end users. So it's really the existence of this centralized SQL server containing all the relevant healthcare and custody information that can be accessed and queried by analytical staff like myself, sitting next to clinical SMEs like Dr. Dunlap, is how all this happens effectively. By combining together my analytical and programming abilities with his clinical knowledge, we're able to quickly produce these operational tools and performance reports. All right, if you build it, will they come? So in this case, we were introducing a new process and a new tool for dealing with end-stage liver disease patients. So our goal in the quality management program is to make it easy to do the right thing. And so towards that goal, we attempt to make our tools easy to use and easy to access. Now, in this case, again, we already had a number of other patients' condition-specific registries, and those were all linked off of what we call a master registry. So we added a column, you can see down here on the bottom right, we added a column to our master registry specifically to identify end-stage liver disease patients. Clicking on that column header in the frequently used master registry brought staff to the end-stage liver disease registry. And that was the exact same method of access they were used to using for all of our other medical conditions that we track at the population level. And so it was an easy and consistent method for them to access the report. As with many of our other tools, we also produced a release memo, which described the need for and features of the registry, and we publicized it with a banner on the homepage of our organization's intranet site. In this particular case, we also had a rule for the end-stage liver disease registry around keeping patients on if they get on once. We basically never let patients off of the end-stage liver disease registry based on our automated rules. And so that created the need for an override process. And so we had to build that override process, essentially figure out what the chain of review for different patients is to see if they really belong on this registry. And then we also looked for ongoing feedback from the field. So we got a lot of feedback as we were developing this tool, but we've consistently gotten feedback since it's been released. So people email us with questions and comments and suggestions. Dr. Dunlap will talk a little bit about that in a little bit too. And then finally, since this was a not very well understood disease for our particular providers, because it's not very common, continuing medical education was produced to educate our providers on the condition and its appropriate treatment and how to use the registry. This training was conducted by a webinar multiple times, so all providers had a chance to view it and get credit towards their continuing education. All right.
All right, thank you, Michael. All right, so was it worth it? So, as Michael said, we had a implementation strategy that was really sort of targeting our end users to make sure that they knew what the tools were, messaging this from leadership downwards, and trying to make the information readily available and coordinating that with medical education and other initiatives focused on improving the care of our end-stage liver disease patients. So one of the things that we wanted to sort of measure was how frequently were people using this registry. And you see it's an interesting curve here. We had good usage in the very beginning, and then we had a pretty good dip. This dip actually corresponds with the introduction of our electronic health record system, which that was when we launched the pilot sites in October 2015. So it seems like it correlates pretty closely there. However, that in and of itself probably isn't explaining it, because only 3 of our 35 institutions went live with that. So we couldn't fully explain it by that, but what we do know is that in early 2016, we also relaunched the initiative with new enduring training materials from our medical services counterpart to really emphasize this, and that's where we saw a tremendous increase in the usage, which stayed relatively high with again some variation, but basically looking at 3,500 to 5,500 hits per month. So definitely getting usage. What did that do? That translated to improved performance in those defined measures, which we're showing here. Again, starting for our composite measure, just over 60%. We actually hit our goal of 90% somewhere in the mid 2016 point, and then we took a little dip again that corresponds really with the heavy implementation of the EARS system across multiple institutions. So right in the heart of 2016 is when we really started to convert in mass to the electronic health record system. We believe we'll get back up to 90%, though even today we still aren't quite there. We're still in the high 80s, so we'll keep going towards that. So again, as I explained in the graph before, the CCH met its goal of 90% in mid 2016, but we did start to dip, and we attribute that to the mass implementation of EARS. Post-implementation outcomes. So some of the things that we found that we thought would happen would be that we'd see a reduction in hospitalizations and a reduction in costs associated with that. But in fact, we saw the opposite, which is interesting when you step back and think about that, which actually an increase in hospitalizations may have been the right thing, which is identifying earlier very life-threatening events and getting them to the hospital for appropriate interventions sooner. However, we did see 30-day readmission rates decrease over the measurement period. So again, starting up in 2013, 27-28% of our 30-day readmission rates were for ESLD patients, and that dropped below 20% by 2017. So return on investment. Here's where the really surprising thing found that we looked at. So we implemented the ESLD registry and dashboard measures again in late 2013, or I'm sorry, mid 2013, and then in 2014 we did not see really a significant reduction in our mortality measures for age-adjusted mortality related to liver disease. However, subsequent years in 2015 and 2016, we see a tremendous decrease in the age-adjusted liver disease deaths. So again, our mortality rate went down to 10.7 deaths per 100,000 men per year. Interestingly, when you look at CDCR's statistics, I'm sorry, CDC's, not CDCR, CDC's statistics, they rank chronic liver disease cirrhosis patients at number 9, and their U.S. rate was 10.7. The state rate is 12.2. And our new rate as of 2016 is looking to be just in line with the U.S. rate and the state rate. So we were very pleasantly surprised at the tremendous impact that we believe these tools played a part in. So, cost. So it took us roughly about 2 full months to actually create the ESLD registries. And so our costs for this, we estimate to be about $43,000 between clinician time and the analyst's time. The administrative costs basically are going to offset the time it took nursing staff and physician staff to review all of the patients' charts to identify those that had liver disease, and then whether those patients had appropriate screening for esophageal varices or hepatocellular carcinoma. So when we translate that to about $100 an hour per clinic hour, which is an estimate that we did off the physician's salary at our hourly rate, and we have about 2,000 patients, we look at an estimated swag cost of about $200,000 a year in terms of savings. But ultimately, the patient outcome mortality reduction is what I think we're most proud of. So, as Michael referred back earlier, feedback loop. How do we get user feedback? In the performance evaluation team and quality management, we are in constant conversation and communication with our end users. So we have a QM staff inbox, which the field can report any concerns they have with any of our dashboard measures and or any of our QM tools. So here's an example of an email that was sent to us that showed a patient was inappropriately being flagged for cirrhosis because he had a platelet count of 35 that elevated his FIB-4 score. However, that platelet count was artificially low due to platelet clumping. When they repeated it, it showed us at a normal range of 285,000. So, as Michael said earlier, this feedback loop allowed people to basically refute the once on only on or once on always on rule we created for patients with cirrhosis. So project outcomes. We believe that we were successful in improving care and reducing costs. So again, we were seeing an increase in diagnoses early on through our methodology. Evidence-based guidelines were being followed as we were able to demonstrate by performance in these particular screenings and also in prescribing NSAIDs. And we did definitively see a reduction in mortality, but perhaps not morbidity, as the hospitalization costs and visits did increase. But again, the morbidity was probably related to the detection of the complications related to cirrhosis as opposed to just more people becoming cirrhotic. And we were successful in leveraging our IT and data. So we were able to identify and track patients more efficiently across the 35 institutions. We were able to provide timely, actionable information to the providers, and we feel we were successful in providing near real-time performance reports to managers and other outside stakeholders. Overall, we have some lessons we felt were worth sharing with you. So a big one is population management tools are value added to your organization, guiding evidence-based decision making. So AI is not artificial intelligence these days, it's maybe more augmented intelligence. So how can you use the technology to help clinicians make smarter choices that are when they're sort of deluged with all sorts of information, and just knowing what to pay attention to and what the right thing to do is very helpful for them. It also can reduce non-value added administrative chart review time for clinicians, so they get to pay attention to the patient. And these population tools are most importantly complementary to front-end decision support. So if you have the patient sitting in front of you, the electronic health record can certainly point you to what you should be doing. But what about that patient that doesn't have an appointment, gets lost to care as they transfer from one care team to another? or they refuse an appointment and then we forget to reschedule them, or they don't ask to be rescheduled. These tools allow us to look at populations, and then if we identify things that are going missing, we can be proactive to call these patients back into the healthcare delivery system. Another big thing is if you don't have an EHR or full EMR, you don't need to wait till you have one. You can leverage your existing data sources, again, pharmacy related, laboratory related, and claims data if you have it. These things can be built and give you it can be leveraged to give you a lot of meaningful information. And then you need to make sure you allocate resources for maintenance and operation of all your tools. Inevitably, IT breaks and clinical care guidelines change. So you've always got to have some maintenance anticipated going forward to maintain your tools, make sure they stay accurate and work properly. And then lastly, you need a system for feedback. So when junk data gets in there, it can be taken out or flagged to be ignored. And that's it. Thank you all again for your attention and time. Have a good day.
Okay, we would like to thank our speakers from the California Correctional Healthcare Services for joining us today and speaking on their Davies use case. We would like to remind our listeners where to go find this Davies use case and other important information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Once again, we would like to thank our speakers today and thank you for listening.